For those of you who were here yesterday, most of you I'm sure, we had a very exciting set of sessions covering a range of topics related to community care and supports for older adults. We heard about many innovative and interesting approaches, some older approaches that are being retrofitted and some brand new ones. And we're going to continue on in that discussion. But before I do the introductions of the keynote this morning, I just want to say thank you to Dan Levitt, who gave the public lecture last night. Thank you, Dan. Fabulous talk. People were resonating about that. It was a super group that we had with questions and answers, and it was a lot of fun. So carrying on with the topic of social prescribing, we're going to be hearing from two Manitobans, Michael Routledge and Kathy Henderson. The topic is social prescribing, innovation through community connections. And this, I think, dovetails very nicely with what we heard from United Way yesterday. Michael Routledge has spent most of his career in public health as a medical officer of health in combination of rural, urban, provincial, and Indigenous organizations. He served as Manitoba's Chief Provincial Public Health Officer from 2012 to 2016, during which time he met Connie Newman, Jim Hamilton, and a number of people, many of whom we know through CAG, who've been working in the area of community care, and they are associated with the Manitoba Association of Seniors Communities. And this, again, developed this idea of the social prescribing that they're doing. Michael's currently a medical advisor with the Public Health Agency of Canada's National Microbiology Laboratory and assistant professor in community health sciences at University of Manitoba. Kathy Henderson, who's also going to be speaking in this dual keynote, works as a healthy aging and seniors care specialist, social support services to seniors in the Winnipeg Regional Health Authority. Kathy is a registered social worker with the Manitoba College of Social Workers. She has extensive experience working with support services for seniors, primary care, home care, supportive housing, community health, and social services and community development. So everything. Without further ado, I give you Michael and Kathy.
Thanks, Andrew. Good morning, everyone. As Andrew was saying, so my background is I'm a physician and spent most of my career in public health. I'm also trained as a family physician, and so I worked part-time as a family doc for 10 years. And this idea of social prescribing really is the kind of thing that animates me, how we connect what we do in primary care, public health principles, and community resources to maximize quality of life for people. So I'm really excited to be here, and we're thrilled about the invitation. So I'm going to be taking a bit of a different slant, and I'll talk about that as I'm going forward, but that's the perspective I'm coming from. I'm going to talk about my experience working in public health and working as a clinical care provider, and what I see as the challenges in terms of implementing social prescribing, and what we're doing in Manitoba to try and overcome those and get it implemented in a good way. So first of all, thanks to the organizing committee for the invitation to be here. Yesterday was fantastic, and it's really exciting to be part of this conversation and growing these ideas. I want to specifically thank some of the folks in Manitoba. Andrew mentioned Jim and Connie. Connie is the executive director of the Manitoba Association of Senior Centers. She's a dynamo. Jim also has many decades of experience working in this space. So if you're ever in Manitoba or outside of Manitoba, because they travel around, and you get a chance to talk to them, please do. They're fantastic resources, incredibly energetic about and passionate about this space. And I would encourage everybody, if you ever get a chance to talk to them, to do so. And also all the folks actually in Manitoba, I feel fortunate that in Manitoba we've got a pretty strong history and track record of supporting older adults and care and service provisions in Manitoba, whether it's home care. It was interesting yesterday hearing the presentation about the men's shed. I did not realize that the first men's shed was in Winnipeg, but I'm not surprised, because that's how we roll in Winnipeg. So I just want to thank sort of the people who have been working in this space for a long time in Manitoba and continue to do great work. And then I want to thank, again, yesterday really was interesting to be here and listen to that. And so as I was thinking about what I was going to say, I mean, a lot of the ideas around what social prescribing is were described yesterday, a lot of the ideas around determinants of health and the impacts of supporting broader determinants, not just sort of the healthcare system, really the limited capacity of the healthcare system to really improve and maximize people's quality of life. It's still something I think the public needs to understand, but I think everybody in this room understands it. So I'm going to not get into that so much. That's the kind of presentation I've typically given over the years. But since that's already laid out, again, I'm going to speak to some of where I see this going forward and what we're trying to do in Manitoba. And one of the very specific pieces, one of the challenges really is, I think it was Gloria who was asking the question yesterday about, the idea of sustainability and how we keep this going forward. And that came up yesterday, right? So we've got funding for a window, and we're going to have to go back and get funding, and we don't know if we're going to continue to have funding. And that to me is a fundamental challenge for this. And so what I'm going to talk about is, in my mind, the way to overcome that is to have ideas like social prescribing, where we link older adults with experts in the community. And for us, it's the seniors resource coordinators that Kathy's going to talk more about, and make sure that they're enabled and empowered to get older adults what they need. That is the kind of thing that needs to be, it shouldn't be sort of like we need to go back and get funding and we need to continue to sort of ask for funds for this. It just should be sort of part of baseline budgets. And so I think there's some mechanisms and some ways that we can start to evolve this. So I thought yesterday was a really good way to set that up, and that's what I'm going to try and talk about. So the question I'll put to you right now along those lines, and I'm going to leave with you to think about, and I'd be very interested if people have comments in the discussion after we're done. And so my question for you is, where are community supports prioritized compared within the healthcare system, compared with traditional aspects, and I call it the illness care system, to distinguish the idea that really what we think of as a healthcare system is not designed to maximize health, it's designed to address an illness situation. And that's a really important distinction, and goes along with sort of what the challenges are for implementing something like what we've been talking about with supports for older adults. So my question for you is, when you think about questions, how issues are talked about at a public policy level, specifically within the illness/healthcare system, when you think about sort of the importance that is placed on services around surgeries or drugs or diagnostic imaging or cancer treatments, and then compare that to some of the community supports that we talked about yesterday and that you're all very well, that you know extremely well. How do those compare? Like, where are they ranked in terms of priorities? Both by governments, and I also say by the public, and this is, to me, one of the learnings that I'm going to talk about a bit in my experience as a medical officer of health, and going through my career, is that, I think it's easy for us to say, well, we just need government leaders to do this, that, and the other thing, but governments really do and should follow the wills of the public. And I think the public understanding of how we need to really maximize health and well-being, it's there, but how do we get them to make that seen in terms of elections and voting and priority setting? So I think there's some ways we can do that. And in terms of communicating with the public, I feel like from a public health perspective, we have been doing a poor job in this. And to me, COVID was a perfect example of that. We knew that a pandemic was coming. And I feel like the public was not ready for the interventions that we were going to have to put in place, whether that was masking or mandatory vaccines or restricting public gatherings, we should have prepared people for that. And so by the same token, I think we can do a better job of really engaging with the public in a way that gets them thinking differently about health and wellness in the context of our illness care systems. And when you think about how governments are set up, so you've got a first minister typically within a government, and then you've got a couple of key ministries. Finance is going to be important, education is going to be important, justice is going to be important. The health minister is often extremely important. And what's on the health minister's plate is rarely community services. So what's on the health minister's plate is people are upset about ER access, they're upset about not getting access to a family physician, they're upset about wait times for knee and hip surgeries, and those are all valid, but at the same time, I think people should be upset about and demanding action on the community services that potentially prevent some of those things in the first place and really contribute to health and wellness. So if we can get that on the agenda the same way, and that, one of the things I'll talk about as I go along is, that structure of how governments are set up to be able to do this. They're not really set up properly right now. And again, I think that's up to all of us to advocate, to say, we need to do things a little bit differently. So that's the question I'll leave you. I'll just have you think about that. And I'd be, again, very interested in hearing more comments and feedback from people about that. So mask, I'll talk a little bit about mask. And again, if you really want to know everything about mask, you'll have to talk to Jim and Connie. They're the real experts. I'm helping them out with the social prescribing work, which has been a real privilege. So the Manitoba Association of Senior Centers facilitates and supports the healthy aging of older Manitobans through leadership, learning, connection, and community engagement. MASK has an extensive network that reaches out across Manitoba through its member organizations and the work with age-friendly communities. MASK is funded by the province of Manitoba to connect with the member groups and deliver on age-friendly. Recently, there has been an increase in funding through the provincial senior strategy, which is great news. But again, it's sort of this ongoing work of maintaining that funding. But there's been some success recently with that, and MASK has a good and strong history of advocating. And certainly Connie, as the executive director, is somebody that in Manitoba routinely the media, government go to for advice and is seen as a real leader in this space. In terms of the structure, so there's a board of directors, there's a team of 14 consultants, there's weekly e-blasts to the member centers, of which there's 88. There's an online monthly member meeting. And then in addition to the work that MASK does at a provincial level, it's well connected to various national pieces of work like the Age-Friendly Reference Group, the Association of Prescribing, and then the National Committee on Community-Based Senior Services. And this is just another pictograph showing some of the things I just spoke to, some of the key areas of work for MASK right now, so that connecting with the membership of MASK and the senior centers, doing the age-friendly work, but it's been doing for a long time. And then recently, the addition of the social prescribing arm of work, which happened, I think it was about 2 years ago. The private donor provided a significant amount of funding to MASK to bring in social prescribing. And interestingly, I mean, the focus for that funder really was to get family doctors using this. And so, that's one example of a challenge that we've been trying to negotiate, because really it's not about family doctors per se, it's about primary care teams. And so communicating that and getting that kind of idea built in. But in any case, in the last 2 years, I think we've made significant inroads in getting social prescribing established in Manitoba. It's certainly on the lips of a lot of folks. And I'll talk a little bit more about some of the work we've been doing and some of the challenges around that. In terms of healthy aging specifically, one of the things that I think Connie and Jim certainly would say that they're really supportive of is the work that the WHO has been doing recently, establishing the decade of healthy aging, but particularly this definition around functional ability. And that, I agree that that's really important. And again, when we talk about systems that people recognize, these illness/healthcare systems that are really designed around identifying an acute health issue, diagnosing and treating it, and then sending people back out into the world. it's not really historically been designed around, maximizing function, around maximizing quality of life, around maximizing health and wellness. And this idea, I think we're seeing this transition. And it takes some time. Historically, people, the main killers of people at population levels were infectious diseases. So they tended to be an acute episode, and you either got better from that or you didn't, and then you can go on. And as we've evolved into more of a situation where we're dealing with chronic diseases, people are living longer. We've obviously had phenomenal success expanding life expectancy. This idea of switching towards health, wellness, and functional abilities is really important. So it's great that the WHO has established that. And so this is a quote from the Director General of the WHO back in 2015, talking about exactly that idea. So we need to shift away from disease-based curative models and towards the provision of integrated care, so that integrated idea, moving away from the old days where, you made an appointment with your family doctor, you went into the office, you described your acute problem, you had 6.7 minutes, and then you left with your prescription or your test requisition. Things are more complex than that. And so we need to create an integrated system that really can manage those issues. So I'm going to talk about my road to here. That started for me, so when I was in medical school 30 years ago, I had no idea what public health was, really had no interest in when they gave public health lectures during med school. What I was taught is that, your responsibility as a doctor is you need to understand making a diagnosis, you need to get the drugs right, you need to know how to appropriately use medications, you need to know how to use diagnostic testing, you need to get the right referrals to the right specialists and do that to the medical specialists in a proper way. And then there was always this, and then there's those community service things. If you didn't really know what those were, you didn't know how to refer to them, that was okay. That wasn't really so important. And I would say that's still true. I think gradually it's getting less true, but that's what my experience was in med school. And so when I was finishing up med school and you have to start looking at choosing what kind of specialty or residency you want to do, I thought I was going to be an orthopedic surgeon. So I was doing electives in orthopedics, and when you're doing an orthopedics rotation, about half the patients on the ward are these really interesting joint replacements of various sorts. It's interesting medicine, it's interesting care, it's interesting surgery. And then the other half are people who broke their hips. And they probably did that sometime in the last 6 to 8 weeks. And they really often don't get better. There was a mention yesterday at the Keynote about a recent article that Andre Picard talked about, where it's saying that, the morbidity and mortality from hip fractures is worse than cancer. How many people know that? I don't think many people know that. So having that experience on the orthopedics ward and seeing how poorly people do after hip fractures and how limited our capacity was to really get people back to their sort of where they were, got me thinking about, how do we prevent that fall in the first place? How do we prevent the disability from ever happening? And that led me down a path into public health, and I haven't looked back. So that got me started thinking about how you do things a bit differently from what the system can do. So then I went into, as I said, I did a residency that included family medicine and worked in family medicine, but the bulk of it was around public health. And so where my brain was changed there was around this idea of, healthcare systems are limited. Again, typically the numbers were presented yesterday, but most of the data shows that about 20 to 25% of population health is impacted by healthcare systems, and the rest of the bulk of that is determinants of health in our environments. And so maybe I shouldn't say not so important. They're very important, but kind of the metamorphosis that we often get in public health residencies is stop thinking about them as important as they are and start thinking about other things that are more important or equally important at least. And this idea that, all we had to do is, if we could just tell people this, we'll just tell them, and then it'll all be good and we'll be fine. And then I went to the real world. And so what I've learned in the past 20 years of practicing public health is that it's complicated. So there's a lot of reasons why systems are the way they are, and history is a really important, teacher, again, that idea that a lot of the systems we have are built on, what happened, the way the world was 100, 200 years ago. And sometimes it takes time to evolve away from that. And then of course, there's a really important function for all the things that we have. But one of the challenges we have right now is, despite the fact that I would say that really everybody, I think, gets this, like when you talk about the idea of community services and the importance of addressing health determinants, nobody disagrees with that. The challenge becomes, how do you kind of get it done? And so there's lots of reasons why this is complicated. One being that the tyranny of the acute, and this is not just in health, but in all kinds of things, outweighs chronic issues in prevention. Those can always wait. We've got to get to the things that are more the critical emergencies, which is why we tend to focus on ambulances and emergency rooms and less on sort of community and chronic care. But again, I think we can all be optimistic that this is starting to change. And I've just listed a handful of examples here that I can talk a bit about. So one of the ideas is the idea of something called My Health Teams. I don't know what the equivalent is in other provinces, but this is what we call it in Manitoba. And so this is really the idea of integrated primary care, integrated primary with community care services. So what you do is you bring a group of family docs in an area, and so if you look at, in Manitoba, for example, I'm assuming it's the same in most other provinces, a lot of the family docs are really sort of still in that standalone. They're doing their fee-for-service work. They don't have a lot of other interdisciplinary team members with them. And then you have other clinics that are, example, regional sort of like access centers, where we have more of you'll have a primary care nurse, you'll have a social worker, you'll have OT and PT, doing some of the more community, having more connections. One of the ideas that we built in Winnipeg was the idea of an access center having quick links to home care, like right in the same building, EIA services, a lot of the other community services. But a lot of the family docs still are in those kind of more traditional, the clinic, it's really just them doing their thing. And the idea with the My Health Teams is to bring them together and say, okay, what do you need to provide good care and to support your patients? And this is the opportunity for them to say, well, it'd be great if we had a social worker, or it would be great if we had a seniors resource coordinator, and start to build those in there. So that to me is a really good example of how this is going to work more effectively over time. Has anybody here heard of exercise in medicine as an idea? A couple of hands up. And this to me is important when we talk about social prescribing, because it's sort of the same thing. So the idea for exercise as medicine came out, I'm going to say 10 to 15 years ago. And it was around this idea, again, it seemed like this sort of feeling like if doctors write a prescription, then that gets valued. So instead of just when you go to see your family doctor, they say, you should go be active. They say, here's a prescription that says how you can be active, and you should look at that and read it. And there was some literature that suggested that worked. So social prescribing sort of follows that same kind of thinking. And we could talk about the language, right? And I am going to talk about the language. Like, do we want to talk about prescribing versus referrals versus, calling it social prescribing or not? But the idea that, like, how can we, again, sort of make patients feel like this is important? How can we make them feel like it's not just it's kind of important, but really communicate it and use tools that make it more valued and more documented, more incorporated into the structure, into the systems, into the patient notes. So exercise as medicine is along the same lines of social prescribing. How about the idea of health in all policies? Who's heard of that? Really? Not too many hands I don't see for that one? Health in all policies is, again, a really sort of innovative idea. It's been championed by the WHO for some time, and I think it's slowly oozing into different areas of work. It's this idea that, again, so if we really want to improve health, population health, we can't just use the healthcare system to do that. And again, that's how our governments are structured. So if you have, if a question around health gets funneled to a premier, or a prime minister, or a first minister, they're going to say, go talk to my health minister. And the health minister is going to say, okay, well, if you got questions about ERs and hip and knee wait times, I'll talk to you, but anything else I don't really have any time for. So all the rest of the health issues don't have a home. And so health in all policies is the idea that if you really want to be effective at maximizing health and wellness, you have to look at this in a comprehensive way. So we need to make sure that when we're implementing tax policy, when we're implementing education policy, when we're implementing whatever kind of policy we can do at a public policy level, we're looking at the health implications of that. And we try to maximize them so they're most effective. And then what I have after that, where I have HCM, so that refers to Healthy Child Manitoba. Anybody heard about Healthy Child Manitoba? Okay, no, I'm not seeing a lot. This was something that started in Manitoba about 25 years ago, and it was exactly this kind of health in all policies approach. And so if you work in early childhood development, this is something that you're probably familiar with, because it was really a sort of a leading innovation idea, I think, that came out of Manitoba that a lot of other people around the country in early childhood development were really excited about. And what was neat about it is that it basically, the nexus of it is that it brought together really the 5, 6, or 7 critical cabinet ministers who were making decisions that impacted on health. So you had a cabinet committee that was often chaired by, the chair would flip around. Sometimes it was a minister of education, sometimes it was a minister of health. But then you'd have the finance minister there, you'd have the justice minister there, you'd have sort of the key decision makers in cabinet. So it wasn't just one minister taking an idea, it was like everybody saying, as a government, we need to do this properly. And a lot of really important initiatives to promote early childhood development came out of that in Manitoba. And I think there's a lot of learnings from that idea and that health in all policies idea that you're going to see more of as time goes by, that we stop thinking about these things in silos and we start thinking about them as more complex, comprehensive problems. New models of housing and this idea that we're gradually moving away from the old kind of like you're either at home or you're in a personal care home. The idea that we can maybe be a little bit more creative about how we do housing. GYB stands for Get Your Benefits. So this is an idea that, again, we know that one of the critical determinants of health is income. And if you're living in poverty, you're going to have a real struggle maintaining your health. So, but again, this is one of those things that family physicians aren't really trained to do. So Get Your Benefits was an idea that we're going to provide some resources for family physicians when they flag this, and then potentially give them places for them to refer to. So again, building that idea of enabling the system, the healthcare system, and the people who work within it to support some of the determinants that traditionally have not been supported by the system. And then the community tax, again, is sort of a similar, one of the things that's happening in Manitoba, and I think it's happening in other places in the country, is this idea that somebody who's on low income and hasn't filed a tax return for a long time. What we know is that people, particularly who are on low income, if they do their tax returns, they can get access to a lot of benefits that they wouldn't get access to if they don't. So again, kind of promoting that. And so if you're seeing somebody living on low income, we're going to support you, because doing a tax return can be complicated and scary. So we're going to help you if you've never done it before and show you how that's going to benefit you. So there's lots of evolvings and evolutions that are happening, I think, that are going to enable us to do the kind of things that we need to do with promoting health and wellness in the community. Okay, right, Kathy? Tell me if I'm getting out of control. Okay. Some of these ideas I've talked about already. When politicians knock on doors, think about if you've ever had a politician knock on your door at election time. Or imagine if somebody did, and let's say it was your health minister. Even better, I would say, let's say it was your first minister. And they said, what do you want me to do? What would you tell them? I think the reality is that what they get told is that, well, I had to wait a long time for the surgery, or I knew somebody that couldn't get into the emergency room. And almost never are they going to hear, well, you need to provide better community resources to prevent hip fractures or prevent illness, or, these kind of more community supports that prevent illness, promote health. They just don't get to the top of the table. And so again, when you think about questions that you'll see in question period, in a provincial legislature, these are not around seniors resource coordinators. They're not showing a clip on the news about how the minister got drilled on a seniors resource coordinator. They're showing a clip about emergency room wait times. So got to evolve that a bit. And I think everybody has a role. So again, this would be great. I'd really be interested in hearing feedback on sort of ideas for how to do that. And again, this idea, that how we kind of need to change the structure, because again, it's this health questions go to the health minister, and the health minister's got a limited scope for this. One of the attempts to try and address that is this idea of creating ministers of healthy living. So a lot of provinces have experimented with this idea. Almost always, at least this is my experience, is that rarely are these ministers sort of highly influential in government. They tend to be a junior person, a junior minister. The work that they do isn't typically at the top of the agenda. So, they have some success and not. But again, it comes back to this. How do we change that up a bit? Which brings us to social prescribing as one potential intervention for this. So this is I pulled off the WHO site on social prescribing and some of the resources that it provides. So people who want to develop social prescribing, there are options. So it's great to see the WHO leadership on this, as it is that we have a Canadian Institute in Canada that's providing some leadership and some coordination on this. So it feels like there's a real momentum to this idea. Again, I would love to have some discussion on the language and how we should title these things going forward. But it feels like there's a momentum, and certainly I feel there's a momentum in Manitoba. And we're fortunate, I feel like, in Manitoba. Again, I've talked about some of the people who are doing some of the work. Certainly our seniors resource coordinators, my understanding, and again, this is not where I'm an expert, but I believe we're a bit of ahead of the game, and we have been in Manitoba for some time, and as getting the seniors resource coordinators funded in an ongoing way and positioned and established. The challenge now is really making them seem to be visible both to the public and in particular to the healthcare system, because the healthcare system and primary care providers play a really important role. I work in public health. I'm interested in this space, and I'd never really heard of seniors resource coordinators till a couple years ago. So I don't think most primary care providers have, and that's what we're working to change. Not just that they've heard of them, but they understand what they do, and they easily can communicate with them. So some of the structure that we put in place around social prescribing in Manitoba, again, this is being led by the Manitoba Association of Senior Centers. The board of directors is supportive. The ED here is Connie, who is really a force of nature. She can just get anybody in Manitoba on the phone whenever she needs to. It's really quite amazing to watch her work. I talked about the funding from the private donor that's enabling this for now, but we are aware, as with lots of these things, it's time-limited funding. So what we need to do is we need to get a culture change in Manitoba so that we can't drop this. Like the system says, it's like we just have to keep doing this because it's mission critical. And that's what we're trying to create. So there's a stakeholders committee. There's a number of arms of this that Connie and Jim oversee. They've created a team to work on this, and that's where I, again, was brought in a more formal capacity as a medical advisor to this project. We've brought in a couple of other consultants to fill the team, including for evaluation, again, to sort of make sure that we're able to describe the impacts of this and build in data. That to me is really important, is that the system starts to count this. So we started to implement the idea that as we create a referral form for a family doc to send to an SRC, that gets counted by the regional health authority. And they track those. And then the next step's going to be, okay, well, so how many people did you see? What were the outcomes of that? Like how many, whether that's, and, so the very easy outcomes are, that people are always interested in is how many emergency room visits did that reduce? But to me, the future is that we're able to show people can tell you their quality of life is better. But that's all starts with collecting that data and doing the evaluation of it. So hopefully it'll do the things that everybody in this room well recognizes, which is foster healthy aging. Again, that integration of the systems, it strengthens the alliance, integration idea, reduces the silos, and builds collaborative impact to facilitate healthy aging. This is more of a visual picture of some of the things I've already talked about. This intersection between healthcare providers and senior centers, age-friendly leadership, the mask leadership, and trying to bring all that together. And then, some of the people that we're trying to reach out to really, and again, our focus with this project right now is the healthcare system. So
We're talking at the provincial level, that's the Ministry of Health. In Manitoba, that's also shared health, thank you. There you go. Anyways, the provincial government level, so in Manitoba, it's that sort of ministry, shared health, and then the RHAs, as well as the associations that support some of this work, like Alzheimer's and active aging, age and opportunity, that MASC has a long and solid relationship and history with. So at that point, I'm going to turn it over to Kathy.
Good morning. Can everyone hear me okay? Good. I'm struggling with some kind of allergy thing coming on, so we'll try and get this out. Just give me 1 second, get some water. Okay. Good morning, everyone. Thanks for having us. Jim Hamilton and Connie Newman, they wish that they could be here, but they were not able to make it, as you were just mentioning. But leave it to both of them to come up with bringing a doctor and a social worker together to talk about social prescribing. They always have a method behind the scenes. So I am going to first, I'm going to take you on a journey in Manitoba, in the Prairie Province, of what support services to seniors is. And then I'm going to tell you how we have a natural connector that will actually be able to make this successful. Okay? So first I'm going to give you some quotes that have come in as we've been progressing through the province. And some of them are, there's some on here, but I'm going to read some on my paper here too. Social prescribing has increased my awareness of services and programs in my community area. I have hope because of social prescribing. For almost 40 years in the St. James community area, I've never known about the supports and services that were available to me until now. Because of you, I have a sense of purpose. I feel like I'm not alone. These are from older adults. 55 and up is the range that have had connections with our senior resource coordinators and have come and said how much it has impacted that first initial contact with them and then continuing on. I like the one that says, "You are our guardian angel." Okay, so what is support services to seniors? So I've been with the Winnipeg Regional Health Authority for a couple of decades, we'll leave it at that. In those couple of decades, I've been with support services for, trying to figure out how old my youngest son is, 18 years. So a majority of my time with the Winnipeg Regional Health Authority has been with support services to seniors. And the interesting thing, and I think someone mentioned it yesterday, when we look at the community, it's not, just over 93% of older adults still live in their own home. So in their condo, apartment, house, what have you. So that leaves the remaining 6.8 living in personal care home or some type of acute care system. So we're working with that 93% of older adults. When we talk about support services to seniors, that is providing programs or access to affordable, accessible programs and services that will promote or maintain your health and help you live independently in your own home. So that is the vision of support services. And interestingly enough, before we came onto this globe, the birth of support services was actually initiated by a gerontologist in Manitoba. So there is the first interagency committee that actually came together in 1970. So it has been around for a good length of time. And we have Manitoba Health, and then we have 5 regional health authorities, Winnipeg being one of them, and that's where I'm going to focus more on today, but I'll touch base on the other ones. So Manitoba Health has the money They provide it to the regional health authorities, and then we distribute it out to ERs, to home care, to all the various other areas, including support services to seniors. So in 1984, that's when Manitoba Health started providing grants. And these grants were actually ongoing. So they actually had a portion of those grants that went towards the actual position. So the position, and I'll go over the key areas of support services in a moment, but they were actually able to have that level of sustainability, okay? In '97, Manitoba Health decided to give the money directly to each regional health authority so that they can start dispersing those grants to the support services to seniors agencies. So currently, when we're talking about the Winnipeg Health Region, I oversee 41 boards, really, 41 community not-for-profit agencies that have over 108 service areas that I will explain in a moment. So each of these 41 boards oversees the fiscal responsibility as well as the HR responsibility, and I have that overall program management piece. We have what's called a service purchase agreement, or SPA for short. We have a service purchase agreement that is a legal agreement between agencies. So we give them a certain amount of grant funding, and then they have a certain amount of deliverables that they reach. So that gives you sort of like the behind the scenes of support services to seniors. But the goal, the ultimate goal I've already said, maintain health and wellness, and to increase people's independence to stay home. But when we look at just on this board right here, it's promoting, I'm sorry, I feel like I'm getting feedback. Is everything okay back? Okay. So support services to seniors is all about promoting a range of those coordinated, accessible, and affordable community-based services, again, focusing on health, independence, and well-being. And support services to seniors actually, a lot of times people are talking about, when they talk about older adults, they think 65, we do 55. And that's pretty fluid, because if somebody comes at 54, 53 and a half with an issue, you know, there's give and take, okay? The other one is determining the needs with the older adult in the community and trying to tailor those needs to address whatever it is that they're needing at that point. A big one is empowering older people to be involved, to improve their health, while taking an active role in obviously the formation and execution of services that they need and want. That leads us right to the volunteers. Without the volunteers, support services to seniors would fall flat. We rely, as you guys do as well, we rely very, very much on volunteers. And that was a very interesting time during COVID. And we're starting to slowly bring our way back to that piece. But what is it, 2024 now? It's been a ride, to say the least. But volunteers are the backbone of a lot of these services. So really trying to strengthen and to support those volunteers and acknowledge them and let them know how important it is. The other goal with support services is reducing or delaying the need for more evasive treatment. So whether it's acute services, institutional care, what have you. What makes support services to seniors successful is partnership, 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 collaborate, collaborate, collaborate. If we didn't have that, we would not be able to provide the services, and that's the span across health, social services, and community sectors, always trying our hardest to use that health equity lens, and obviously that intergenerational, the cultural, multicultural, and Indigenous lens as well. Okay, how do we do this? You can tell I'm a social worker. In the middle of this circle is the older adult. Okay, it's very, very person-centered. Okay, we are not going to make something and say, this is what we feel you need. We are a true fact that we are actually aging in place. So we are also investing in our future. So why wouldn't we want to do a good job while we're doing it with all the other agencies that we're with? So when we look at these strategic approaches, with the older adult being that center, we're going to look at finding ways to create supportive environments for these programs and identify any concerns, potential partnerships, because you always hear that phase, how do we leverage resources, and any opportunities to help meet those needs. Somebody mentioned yesterday working with, working for, all those wonderful things. We work with. That's the first thing that we have to do, because if we don't hear from people and we don't work with people, it's not going to work. I'm preaching to the choir. Social engagement, ensuring their involvement, not only in participating, but the involvement of the creation of what is going to, what they're needing. Public awareness is always an interesting. Ever since I started, I've always called support services to seniors a hidden gem, and how do we highlight, how do we showcase, how do we tell them how we give them peanuts and for funding, and they make complete miracles of what they're doing. But it's being able to ensure not only that older adults know how to find and access information and services, but the service providers as well, their family members, spouses, so it's all encompassing. It's like I feel like I'm on a road show all the time, trying to reiterate and tell what support services to seniors does. Then we have promoting health and wellness, and I've already talked about that, so I won't say too much anymore. The building age-friendly communities, we talked about that yesterday, but really supporting those communities to make it easier for older adults to stay active and healthy, and so that they can contribute. And this is for every age. I always tell people when they're understanding what building age-friendly is, I always say, think of our Winnipeg Transit. Years back, we used to have 3 steps to get on to a transit bus. I don't know when it came, but one day, all of them had been transformed, probably replaced actually, and they actually have a ramp that comes down to the actual sidewalk, and the ramp will come out. This is good for somebody in a wheelchair, a walker, crutches, or a mom with a stroller and 3 kids. Okay, so it's that age-friendly piece that you think of, how do you make the environment adequate for everybody so that we can all thrive. The age-old combating ageism. Great talk last night that touched base on ageism, but it's that continually working with public to transform that negative age-related perception and stereotypes, and in place develop an appreciation for the vital contribution that older adults and all of us, each and every one of us today make. I had an interesting part about COVID is I stopped highlighting my hair, and when I came back, interesting how people talked about my hair. Wow, I don't even know, I'll talk about that after. I did have some really cheeky comebacks though, so that's a good thing. So support services to seniors, what are those service areas? The top one I put up in here, the first bullet, is the senior resource finders. If I had 30 minutes or 30 seconds to talk to you in an elevator, and you wanted to know about support services to seniors, I would say, know your local senior resource coordinator, because they are the information and referral hub to connect you with programs and services in the community area. That was less than 30 seconds. There's more, though. They do a lot, and I'll touch base on that as we talk about social prescribing. The next thing within support services to seniors is we have something called tenant resource coordinators. They are attached to 55 plus housing blocks, independent living. And that coordinator works with the tenants or the older adults to coordinate and develop a service plan that suits their needs. So is it they need access to an income tax clinic because they haven't done it in a few years? Because their numbers and they're daunting and they just don't want to do it. And they didn't realize that they had benefits waiting for them. So they will actually coordinate and have clinics come to the blocks to them. It's an amazing process in Winnipeg. It's quite, the tenant resource coordinators really kick it up around tax season. So that's one of the services. I knew my voice was gonna go. The next one is foot care clinics, for example. Well, a foot care nurse, can they be brought in? Do they have a shuttle to go and take them to? All those types of things. So you get the gist of it. Food security, all those types of things. Okay. Meal program is self-explanatory in the sense as it's in a particular, it could be in a 55 plus block, senior center, community center, basement of a local church. Doesn't matter as long as there's access to, it's accessible, access to, what's it called? Commercial kitchen. Then they provide hot, nutritious meals, lunchtime or supper time, Could be 3 days a week, could be up to 7, really depends. So they have a cook or a chef. We're changing, we don't call it congregate meal programs in the community because that sounds very bureaucratic and very institutionalized. So I should make a point of that. That's what government calls it, and that's what I have to call it sometimes, but I get to have those two hats where I get to come out into the community and we call it Bistro 64 or fine dining experience at the Wellington. Things like that, so it's the marketing piece. But the important part of it is it brings people together. You're able to have a good meal, and it's affordable. You get to see the same people every day. COVID was interesting. Public health orders, nobody goes beside anybody. So they had to pivot and be innovative. Now, interestingly enough, those meal programs have found more isolated seniors needing those programs all along. So they also were able to deliver in the community or have people come and do pickup. So now they're actually doing a hybrid because those introverts out there sometimes don't always want to come to a meal program, but they need to eat. But coming down and saying a few highs for a few minutes is like fills their social cup, and then they're good. Whereas other ones need to come and do the whole piece. The next one, we don't call them senior centers in Winnipeg hardly anymore, or even rurally, my counterparts, 55 plus. Center, active living center, that's a focal point where people are going to come together for an obscene amount of different programs, okay? And I won't get into that at this point. The WRHA also has regional older adult organizations, such as Meals on Wheels. Alzheimer's Society has something called the First Link program, where service providers fill a referral form and send it to the Alzheimer's Society, and that system navigator will actually connect with them, okay? CNIB, and we do have, I could talk for an hour about A&O support services for older adults, but we don't have time, but they have a lot of social workers on board to help with older victim services, elder abuse services, counseling, grief services, legal, I think I already said that, but legal services, the sky's the limit with them. But the thing is that if you look at the first four, my counterparts in the other health regions, and I'll show you a map to sort of draw out where each regional health authority is, but they all have the first four. They all have senior resource, and it's interesting, we call the actual service areas called senior resource finders, but the position is called senior resource coordinators, just to confuse you guys, because we like to do that in Winnipeg, apparently. I didn't have a part of that, just so you know. So you'll hear it interchange, senior resource finders, senior resource coordinators, okay? But they have it in all of the other four regions, as well as the tenant resource, the meal programs, and the 55 plus. Okay, so you see this beautiful map that we have, and I don't know if you guys you won't be able to see the writing on it, but just to give you an idea, I don't know if this is gonna work for me. I don't wanna mess it up. Will this do the, oh look. Learn something new every day. If you look at the top, right on the top here, sort of the mustardy color, that's the northern regional health, okay? And then this sort of a, I don't know, greeny kind of color, army green I'd say, is Interlake Eastern. Then we have sort of the blue color here. We need better colors, I think, but the blue color here is Prairie Mountain Health. And at the very south of Manitoba, surprisingly enough, is called Southern Health. The little red dot right here that you see is Winnipeg, okay? Just so you know. And those, we used to have 12 or 13 regional health authorities at one time. It was very confusing. And about 10 years ago, maybe not even that much time, I can't remember, they brought it down to the 5. And who knows, changes happen, but at this point, this is what it is. And if you look at the very, very top there, Churchill is connected with Winnipeg, because a lot of times the people will fly down to Winnipeg for any type of health related issues that they need to deal with, surgery, what have you. So back to the senior resource coordinators. Information referral hub, they're the natural system navigators, because they know how to connect and link and figure out where the gaps are, opportunities. And they're located in each community area. In Winnipeg, we are broken down to 12 community areas, Okay, and there's a coordinator in each of the community areas, but they will customize and look and see what those needs and opportunities are. I always tell people it's available resources and services, because a lot of times there's gaps. So we all know transportation is an issue no matter where you go, and especially in our rural counterparts. The senior resource finders are amazing, but they can't solve some of the system issues that are out there, right? So they know available transportation options, they know yard and home maintenance pieces, they know where the meal programs are, they know where the 55+ centers are, they know if somebody's just lost a spouse and they're grieving, they know to connect them to A&O, all those types of things that they're able to have that link. They are the 2-on-1 in person, I always say to people. So they know what they're able to get to and how. And the big thing with them is they work with older adults, but they have a lot of service providers connecting with them within the WRHA and elsewhere. Family members are always calling them, spouses are always calling them, so they're getting calls from all over, and they always have been getting those pieces. So this is just to give you a quick overview. This is a really pretty map of Winnipeg, and these are the community areas. And I won't get into all of them, but you can see that they're all broken down. Those lines, those boundaries aren't solid. They're also fluid, so if somebody gets a call, a senior resource coordinator in St. James gets a call from somebody in Transcona, they're gonna let them know that there's a senior resource coordinator in Transcona, but how can they help them today? Okay. And if they call back, they're still gonna talk to them, okay? So, when you look at this, next slide here, this is what's happening in Winnipeg right now. Social prescribing's almost already happening, because we already have the connectors, the link workers. They're already there. They know who to connect with. They know what they're supposed to be doing. So we're making it more formalized now in the process of, we're probably in draft 2, draft 3, I don't even remember, of the referral program that will go into our electronic medical records and be used by the physicians, physician assistants, nurse, any kind of healthcare provider in that sense, so that they can send it off to the senior resource coordinator, who they are going to know as the information referral link. And then that senior resource coordinator is going to come and start working with that older adult and what the actual referral form was asking. So it could be meal programs, but then they're going to talk to them a little bit more and find out that the reason why they have the meal programs is their spouse died and they no longer want to cook and have supper at home, or they don't know how to cook for one now, or they never did. It was always their spouse that did it, and now they don't. They have mobility issues. They don't quite know how to do it, or their income has halved, right? So they can't afford food by the end of the month. So what do? Right? So it comes on to those types of pieces. So they're in a natural position to be that link worker or connector to link between the docs and the community services, okay?
Should that be bridging the gap rather than briding the gap?
Yeah, it should be. No one caught that. No one caught that. I'm not gonna correct it right now, but they're definitely gonna bridge that gap, to say the least. Thank you for that. We'll have to change it one day, or maybe not. Good for audience participation. Just sees that you're awake, and I appreciate that. Anyway, so the journey in Winnipeg. At this point, we started now remember it was 2022 that mask was approached by this private donor. It took a while to get things up and running. If I could have changed this last night, who was here? Somebody was here doing the panel. I'm no longer calling it a pilot project, it's a soft launch. So we're going to be doing that. And we started that in December of 2022 in St. James, this community area, St. James, Assiniboine, south Assiniboine community area. And then we had Transcona as another community area. These were natural fits at that point. they're already receiving referrals from multiple sources, like I've already told you, from social workers, dietitians, from the heart teams, from my health teams, all those types of things. But we started taking the stats of the actual doctors' referrals last July. So it looks like in St. James in that time, because we stopped it at the end of the fiscal year, we're still continuing on, but we stopped it for this purpose, for the end of March of 2024. So there were the 20 referrals from the docs in that sense, because they had just started getting going, as well as 17 in Transcona. But wait, interestingly enough, even though we were doing the soft launch in those 2 community areas, the remaining 9 community areas had a total of 56 referrals already coming in. They're like, hey, man, we're already doing this. Let's get going. So a total of 93 at this point. And there's more. The referrals are coming in. It's interestingly enough, I looked last night on the stats, because we get all these organizations, they have to send monthly stats to us. For the senior resource finders, in the fiscal year of April 1st, 2023 to March 2024, they had over 41,000 individual contacts and services provided to older adults in the city of Winnipeg. So it's there. What we're doing is we're getting the medical field to catch up and realize that they can make these referrals and let them know how important these people are to help older adults in the community area. And the same things are happening in the other regions that I'm with, or my counterparts, but we're all at different stages. The Winnipeg has done it a little bit longer at this point, but they're all on board. They're all getting there. And they also have the senior resource coordinators already in place. So, we have the privilege of having Dr. Verena Menick, who's recently retired as a senior scholar from the Department of Community Health Sciences at the University of Manitoba. She has graciously and willingly wanting to come on with MASS to be the research consultant. So she has started looking at an evaluation process. I don't know how much you can see in the back there, but the overall result is seeing the increase of social engagement among older adults. So she's really looking at navigating the landscape, looking at shifting the awareness between the provincial regional health authorities, so those 5 regional health authorities, the community areas themselves throughout the whole province, getting primary care on board and understanding what wealth of resources are available. And also, remember how I said I had just in Winnipeg those 41 boards? So letting them know what's going on so that those senior resource coordinator boards, as well as the coordinators themselves, have an idea. And really changing systems along the way. Really looking at getting that referral form on electronic medical records. Remember how I talked to you about a SPA, the service purchase agreement? They're already referring and linking, so they're already really doing this. It's just a change of wording, change of slight focus on that piece. But again, it's at it all, how does this keep on going? Where's the sustainability? Where's the funding? And that point. The good thing is that the senior resource coordinators have some funding towards their position. The boards also accept donations, look for different fundraising, and other grants, as you guys in this province actually do, I'm sure, with the community organizations that you work with. So it's really looking at leveraging those existing resources. That's where that natural fit came. And again, looking for that funding piece. But the big thing is strengthening that leadership and capacity and being able to make that last row, the province itself, including the docs and including the senior resource coordinators or support services to seniors in general, because we're educating everyone to know how important this is. And Dr. Menick, is leading the evaluation and looking at that individual level, what's the amount of referrals that are being received, and how is it going along with integrating that into the actual service purchase agreement as we move forward. I am going to end my section and have Mike come up again, but I want to finish by playing this very short video. I don't know what we're doing on time, I'm sorry. We're getting tight. Oh my goodness. Okay, I'm going to play this video, and we're going to be able to see how support services to seniors, the senior resource coordinator, had personally helped this one individual. So let's, fingers crossed, hope this works.
Hi, Martin. It was great to see you again at the Pros Knows Expo. I wanted to reiterate what I said to you at the Expo. You are one of the most important people to me. I'm so thankful that I met you at the display in Grant Park Mall when I first moved to Winnipeg 5 years ago. Recently retired when I moved here, I knew one couple and was attracted to the city by its affordability and rich cultural opportunities. Until I met you, I did not know that Winnipeg was also a source of a multitude of valuable resources for seniors. Because of you, I connected to the Charleswood 55 Plus Senior Centre. That is a tremendous organization, keeping seniors connected, fit, and inspired. I've made many good acquaintances and several friends through that club. Because of you, I encountered the Winnipeg Leisure Guide. Through that service, I learned to cook East Indian food, took up line dancing, and took painting lessons. Actually, line dancing and painting continue to be my favorite pastimes. Because of you, I made a good friend with my 94-year-old next-door neighbor. You alerted me to some event in town, and I invited her to go to it with me. We hardly knew each other at the time, but have become fast friends since. That has been one of the greatest gifts. Because of you, my friend was introduced to the internet and how to use an iPad. That has made an amazing difference in her life. She uses it mainly for emailing and texting, but it has brought her closer to her nephew and his wife, who are her primary caregivers. She can also watch YouTube videos and project from the iPad to the TV. As more things require online connections for making appointments, she's able to work with that. I look forward to your monthly e-blasts. The jokes are great. The list of services provides a good reminder of what's available. The alerts for events and workshops open new worlds for me. The fact that you continued this through the COVID lockdown made me feel still connected to our community. Because of you and your service and hard work, I do not feel isolated or lonely. Thank you. Hi, Martin. It was great to see you again at the Pros.
So we're done, Andrew. Yep. I'm not going to go into too much about what we're working on. Basically, we've been working on a referral form. We've been working on communicating the idea. We've been working with the Regional Health Authority leadership and clinicians. Clinicians are really supportive of this. The leadership tends to glaze over a little bit. That's going to be our challenge. And so again, as I talked about, is really how do we get this to be sort of prioritized in a similar way. So I'll just leave it there, and any questions that people have. Thanks.
I'm going to jump in, and there's other Q&A. Maybe I'll bring if you want to come up here. Want to come up here? Want me to bring it back? Or want me to bring it back there? Okay. First of all, I'm going to just jump in. I want to thank you for the terrific presentation, extremely informative, and it's really interesting to see how things are being done in Manitoba and compare that to BC and New Brunswick and so forth. And each province does things a little differently, as we know, and I think we can learn a lot from each other. So I really appreciate you coming here and flying from Winnipeg and participating in this conference. I asked the same question of Bev yesterday about the United Way social prescription efforts using community connectors, which is, I think, analogous to your resource coordinators or finders. But you brought in the primary care system, and I think that's quite novel and challenging. So it'll be interesting to see where that goes. But the question I asked Bev, and I'm going to ask you as well, is this. How do you, I know you're doing evaluation, and it's great you got Verena Mennick. She's a colleague of ours from CLSA, and she's done age-friendly community work, and that's terrific. But how do you do the evaluation so you establish coverage? That is, you're including the hard-to-reach people, socially isolated, marginalized, indigenous populations, and so forth, and you're including, how do you make sure that those people are being brought into the system? In order to get long-term funding sustainability? Tough question.
No, it's a good one. I like that, actually. The interesting part is with support services to seniors, that's always the million-dollar question, as with everyone. But the interesting thing of bringing primary care into it is some of those older adults that don't have any knowledge of any of support services, and having that doctor be able to fill out that form and cue in on that, that's definitely where I see that little bit of light to be able to, once that any type of health, primary health professional or provider that can fill out one of those forms and send it in is a win, because we don't always have the because of you people where it's happenstance that she was able to connect with Martin, the senior resource coordinator, to start linking. And there's also those different parts where finance is obviously an issue, or transportation. So
It'd be great if it could also be done in the emergency rooms
Absolutely.
and clinics.
And that's another good point, actually. And when I say I feel like I'm constantly on this roadshow, especially this year after COVID, because there has been such a changeover of staff on every level, that I'm going to my health teams to let them know who the senior resource coordinators are. I'm going to the social workers within the WHA and the community and hospitals and saying, this is what we do. Please utilize us. Please partner with us. And doing it with home care, and the list goes on. Want to add to it?
You know, the only thing I'll add, Andrew, is that to me the answer is that again it goes back to that prioritization piece, because you could set up the tools to capture that kind of data, you could set up the system to do the analytics. The question is that are you going to put the effort into doing that? And so the system has to decide this is going to be important. So as an example, like one of the things we have in Manitoba, we've had for many years, is the university has the Manitoba Center for Health Policy. So they do constant deliverables for the system, and basically we have a mechanism where everybody in the healthcare system puts up their hand and says, I want the MCHP to do this year. So when we start getting people to start saying, we need the MCHP to do the analytics you just said around seniors resource coordinators and the impact and the health improvement metrics, they can do that, but we need to create the urgency to get it done and to get it analyzed. And when that happens, then we'll be able, I think the mechanics of actually doing the research and the data analytics are doable.
Hi. I feel like this is a bit of the elephant in the room with social prescribing, because it's about utilising the resources that are already available within the community. And we've got many people from working within community organisations here, but those organisations, as you've already alluded to, don't receive, their funding is unstable. And therefore we're building a system around a sector that isn't appropriately funded and increasing. If social prescribing works well, that means those organisations receive more referrals, which I think we all agree is great, but those people will have increasingly complex needs and the funding isn't there. And we talk about shifting ways in thinking, but we also probably need to shift resources, because while we all want more resources, I think that's a hard sell to the public to pay more taxes. And you might detect from my accent, I come from the UK, where social prescribing is much more evolved, and this has been a real problem in terms of clinicians being very supportive and the model being embedded with health, but the community sector has faced years and years of defunding. So I was just wondering, is this a conversation that you've had in Manitoba, and how do we influence policymakers, and how can we advocate for more sustainable funding from the sector on which this whole premise revolves on? So.
Yes. My question totally follows her question, because I was trying to figure out what is the difference between Manitoba and here, because you didn't talk about senior centers and the fact that they existed. Here, senior centers and community-based senior service organizations are struggling to exist. You know, funding remains an issue. So you talk about all these programs, and for me, if we really want a viable social prescribing program, a viable aging in place program, firstly, we have to have long-term core funding to senior centers and community-based senior service organizations. Because without that, I mean, you talk about Manitoba, that already exists. But here it doesn't, and I think that when we talk about it, that has to be one of our number one priorities. Thank you.
I love these questions. Thank you. That's actually quite important. And the one thing with Manitoba is when it started in the 80s, it was ongoing funding. So it was never something that they had to reapply for or feel that from year to year it was going to be taken away. So is it enough funding? I'll let you guys answer that. But we're always advocating to increase those funds to policymakers and government as it goes on. And it was interestingly enough, just before the election, the support services to seniors had a 25% increase in their funding, which was well overdue, but we still advocate definitely for more, because it is grant funding in that sense.
To me,
time for only 2 questions, Ben?
I think Mike wanted to.
just to add that to me the solution to that challenge is that join up with an influential partner. And to me, the natural partner is the healthcare system. So if these service programs can be seen as an integral part of the healthcare system, which I would argue they're not currently, if they can be seen as a more integral part, then the ongoing support and base funding will follow.
Thank you, Kathy and Michael, first of all, very much. It was so interesting to hear about Manitoba after the feedback we got on our talk yesterday about the SP in BC. I've got a whole bunch of questions. I'm going to bring it down to your work with older adults in the design and operation of the seniors services. And I say this because I think we have about 10 people in the room, older adults, all of whom are involved with various action tables, community-based action tables. They are retired professionals. They've made a lot of policy changes at the local level in terms of age-friendly, but they're in the room, and in connection with that fact, and I'm sure you have the same in Manitoba, I remember your evaluation. I took heed after the question we got yesterday. In the couple last slides, I noticed that the outcome was social engagement of older adults. So my question is, how do you get social engagement on the part of the older adults in the processes involved and all those things that you were evaluating? It's so important. They hold so much knowledge.
Well, I'll just start by saying, I mean, it's too bad that Connie and Jim weren't here to answer that question, but part of it is that, so we talked about the structure for the Manitoba Association of Senior Centers and how they're closely connected with all the organizations around the province, their board, I was just, a couple of weeks ago, we had that meeting at the Keynote Center. I'm not exactly sure, that was a consultant, what's the board, I guess?
Those were the consultants.
So they have really strong mechanisms to make sure that that's happening.
It's interesting because all the consultants are retired in that sense. Most of them are, and they're professionals in that sense, and they know they're definite strong. Connie looks for strong advocators because that's what she is. She's probably one of the best advocators I've ever met for all things older adult wise. So, and even in the boards that we have, older adults in the process of having those services and that they're engaged that way. Also in the people, because when I first started 20 years ago, it was interesting when I saw some of the programs that boards thought or the senior or whichever support services to seniors staff felt was good, and nobody showed up. They found out pretty quickly. In that sense. So they started engaging and doing those surveys and doing those community forums and asking for feedback and things like that. So it definitely comes into play. I think that's as far, but you and I can definitely, I need your name and number because I think I want to actually connect with you on multiple levels moving forward. Thank you.
One last question.
It's actually 2 questions. One is for the panel and one is for the group. The panel, you have an Indigenous premier, and I'm wondering, has that impacted at all awareness of Indigenous practices, social practices in terms of health?
What a great question. I would say the quick answer is yes. And I mean, I would say that's been building. Like, so Mr. Canoe being elected wasn't kind of like, it's been a continuum of what's going on in Manitoba, I would say. You know, so I spent COVID working for an organization, and BC actually to me has always been the leader, if you know the First Nations Health Authority and familiar with their structure and the work that they've been doing. So in Manitoba, we're doing something similar. I mean, basically what's happening is you're seeing devolution to Indigenous organizations. So in Manitoba, we have really two sort of tribal councils. We have one for the north and one for the south. They're both building their own health organizations. For COVID, I worked for the health organization that represents the 32 First Nations in northern Manitoba. And so, I mean, to me, we're seeing this happen, and certainly one of the things that we've been talking about for a long time with social prescribing is bringing in that Indigenous perspective. You know, I mean, the value of elders and what elders can bring is really important and a great resource and asset in Manitoba. So it's a great question. We're definitely planning to build on it. Actually, I think when Connie and I get back, we're meeting with the Manitoba Métis Federation sometime in the next couple of weeks, and you know, we're continuing to do that. So it's happening in Manitoba, and we want it to be a part of the work that we're doing. We didn't actually talk about it, but it's really, we want it to be an important part of what we're going to do.
I think it's important to say that MASC also have connection with our Indigenous Senior Resource Center. That wasn't mentioned either. And there is an elder resident coordinator, which is like a tenant resource coordinator in one of the blocks in Winnipeg. So they're also having that connection with MASC as it moves forward.
Thanks. And the last question is to everybody here. It's just been announced that we have the Hospital at Home program coming out of the health department, and it's releasing people as soon as possible out of acute care situations to home with a pile of resources. And my question to everybody here, because I don't know the answer to this, has that model, they're giving physiotherapies, doctors, nurses, that kind of group, has that model included social prescribing? That is there somebody from the community on the team who is directing, I guess, the patient or helping the patient find the resources in the community so that they can get better faster?
Does anyone want to answer that? I mean, I suspect there is, because there's already social work, placement, and so forth that connects people.
Yeah, I was going to go find you afterwards, but since I have the opportunity. So with the Nursing Home Without Walls program in New Brunswick, through that collaboration and through home care, knowing, and our program is called extramural program, so that's our home care, so it's basically the hospital without walls. And through them knowing the existence of Nursing Home Without Walls for aging in place, they will now, if they know that they're visiting a client or someone at home and know that in that region there's a Nursing Home Without Walls program, they will connect that person to us and make sure that there's a visit that happens and that follow-up does happen. Of course, it's not available in every community, but there is that linkage. And I think it's knowing that the program is in that area and letting home care know that this is happening in this community, and for them to be able to do that linkage. Yeah, and it works wonderfully. It's really a back and forth referral. And there's openness there to us having access to physio and OT without going through a doctor's referral as well. So if we do a home visit, realize that there is a high risk for falls, we want that home to be evaluated and that person evaluated, we can automatically reach out to home care and ask for a visit to be done. Yeah.
Thank you. Yeah, there's something similar in Ontario. I just went through it with my mother, who's 98 years of age. And I think in BC we have something similar in that regard. I think we can carry on this conversation during break. We've kind of gone over, and I want to take this opportunity to thank both Michael and Kathy for the wonderful presentation. So on behalf of everyone,